Good morning and welcome to today's webcast, 2019 Medicare Regulatory Update for Skilled Nursing Facilities. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenter from Moss Adams, Paul Holden, a partner in our healthcare consulting practice. And Paul, I'll turn the line over to you to get us started.
Thank you, Emily. Well, good morning, everyone. We appreciate you being with us today. Our topic for this morning regarding the final rule for skilled nursing facilities, we've got a lot of information to cover, some of it new, some of it a refresh, some considerations outside of the normal regulatory update environment. We're going to talk about the OIG and also compliance considerations. I know many folks on the line have been actively working with their compliance plans over the past 5+ years as the ACA rolled out new requirements for skilled nursing. But we're going to go through first these items in terms of the final rule. We're going to talk about this new transition to the payment-driven payment model. We're not going to get into detailed specifics at the clinical level or really unpack the PDPM in a granular fashion, but we're really going to talk about it more from why CMS is going with this approach and how folks can start to prepare as we head into October 1st of 2019, when we will formally transition away from RUG 4 to PDPM. So for the final rule update in a broad sense for fiscal year 19, we had a 2.4% market basket update to our base payments. This was actually a percentage that was required by the Bipartisan Budget Act this year. Overall, SNF payments are going to increase about $820 million on a gross basis, but they will be netted down for the reductions for the value-based purchasing and other quality programs that CMS has put into place. CMS did move forward with finalizing this transition to PDPM. Now, earlier in the spring, we saw an advanced rulemaking that CMS issued proposing what they were going to call the Resident Classification System, or RCS-1. From what we can see and what we have heard from lobbyists and others, PDPM certainly on its surface appears to be less administratively cumbersome from RCS-1, but it's going to also be a significant change from the current RUG 4 that we are working with right now. And with that, we will actually start with our first polling question, so I will turn it over to Emily.
All right, our first question, do you or your team regularly review CMS's rulemaking? And your options are yes, no, or I'm not sure. And I'll give everyone a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. And let's take a look at the results. Paul, back to you.
Great, thank you, Emily. This is about the distribution that we would anticipate. It's typically about a third of folks who are going through and actively reviewing the rule. The SNF rules each year aren't terribly long, typically somewhere between 100 and 150 pages of content with supplemental tables. With the recent changes that CMS has been bringing down, certainly as they have hyper-focused on the ultra-high therapy RUGs, actively working with the OIG. We would encourage all on the line to the best of your ability, maybe not necessarily the proposed rule, but certainly the final rule over the summer, to either find an opportunity to review that as a management team or to reach out to your reimbursement or legal counsel to interpret what CMS is changing year over year. So as I mentioned, for the market basket adjustment, we're looking at a 2.4% net market basket update. The market basket updates are always on a gross basis and then are netted down for certain items. This year, the multi-factor productivity adjustment was still in play. That was an element that CMS had implemented, basically saying that over time, even under the prospective payment systems, providers will become more efficient in their daily work due to technology advancements and other areas. So we need to account for that as part of our consumer price index. So originally the adjustment was going to be 0.8%, but the BVA limited that to 0.3%. So that's where we arrive at our 2.4%. Now, for skilled nursing facilities who are not meeting the QRP requirements, the market basket update is actually going to be a negative 0.1%. So it's very important that providers across the country are making sure they get their quality data in, not only for the market basket update, but for star ratings and all of the other items that CMS reports out. For this next year, under RUG 4, the 128% add-on for SNF residents with AIDS still remains in effect as well. So just a quick note on the market basket adjustment, because it will be interesting to see how CMS continues to implement this. CMS uses the Medicare cost reports for providers of all types to make most of their calculations in their rulemaking. So for skilled nursing facilities specifically, in order to update the market basket each year, they're using routine services, ancillary services, and capital-related expenses in order to determine over a period of time what the change has been in the costs of goods and services for skilled nursing providers, acute care facilities, inpatient rehab, so on and so forth. CMS uses what's known as a L'Esper's type market basket adjustment, where they're taking a fixed set of goods and services and measuring the change in those goods and services over a broad period of time. So it's really important when you're completing your Medicare cost report that it's not just seen as an annual filing drudgery requirement, but actually as an opportunity to demonstrate and show CMS what the actual cost of doing business is out in the marketplace. So for our per diems for fiscal year 19 for urban and rural providers, this is the distribution of the per diem amount between the various categories, between nursing, therapy non-case mix related, and then those non-case mix adjusted expenses. So at a high level, you can see the impact there. And with that, we will move to our next polling question. Emily?
All right. Our second question, in the past year, has your facility reached out to acute care providers to discuss wage index trends in your marketplace? And your options are yes, no, or I'm not sure. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. I'll give everyone a few more moments to make a selection. And let's take a look at the results. Paul, back to you.
Great. Thank you, Emily. This was an item that we wanted to bring up. Myself and my co-leader here at Moss Adams and Reimbursement, Glenn Bunting, we talk quite frequently throughout the year with skilled nursing providers who are looking at their wage index values and noticing that the acute care providers in their marketplaces are driving wage index values that in some way, shape, or form, and we don't need to get too far into the detail, but there is an impact for the skilled nursing providers from the wage index values that are generated at the acute care level. I would encourage all folks on the phone to actively review your wage index values for both your CBSA as well as your surrounding CBSAs year over year. And if you're noticing certain trends in your market area, going out and communicating with either consultants or counsel or acute care providers in the marketplace to make sure that all provider types are working in unison, because there can be a lot of unintended consequences of changes in wage index values year over year. So we wanted to highlight that as part of this presentation, because we're seeing more and more that there's communication from skilled nursing folks where their wage index values are going down, even though the cost of their labor is actually going up year over year. So something just to actively manage from a reimbursement perspective. As a reminder, for Medicare Bad Debt, we have now fully transitioned to the 65%. Previously, for skilled nursing facilities, we were up in the 100% area. So it's really important that while Medicare is at least paying something, that we're claiming those deductibles and coinsurance amounts for reimbursement. At least in the last few years, even when President Obama was in office, reduction of Medicare bad debt to 25% to zero has been active both on CMS's mind as well as part of the president's budget. So we definitely still encourage that this is an area to recoup some lost reimbursement while we can through the cost report. So moving into this patient-driven payment model, effective 10/1 of next year. So we have just about 11 and a half months or so to get ready. Really what the PDPM is driving at is CMS was looking for a way to create a reimbursement model that would be dynamic and change with the acuity and the improvement in a resident's condition over the duration of their stay. Historically, when the OIG has reported back or CMS has unpacked RUG 4, a lot of complaints on their part is information is going into the MDS, it's developing RUGs that are really reflective of the higher acuity condition of the resident when they're entering the skilled nursing facility. And what CMS was seeing that over the duration of their stay, CMS was still paying a particular RUG based on the needed therapies and other ADLs for that particular resident. But when they looked at both the reimbursement data and the demographic data side by side, they couldn't tell that the resident was improving in their condition, even though all of this high-intensity therapy and other care was being provided. CMS started to address that by taking the components of the previous system and starting to unpack them and look at them from a different perspective. So CMS, in terms of the provision here, decided to bifurcate, which is just a fancy word for dividing, the nursing case mix component, which previously we had the nursing case mix component that would be adjusted for the acuity of the patient and transitioning that into both nursing and non-therapy ancillary services. So what they're accomplishing there is they're taking the nursing costs and then they're also identifying drugs and supplies and other items needed for patient care, and they're splitting those two into two components separately from one. And then consistent previously with identifying therapy separately, they're now looking at PT, OT, and SLP separately, and then they are eliminating the therapy non-case mix component as well. So what they're intending to do by splitting these various case mix components and service lines is they are wanting to basically say how much further could we break down the various inputs of patient and resident care so that over the course of a resident stay in a skilled nursing facility, can we have a dynamic model where the reimbursement is more reflecting the intensity of care being provided? And it's interesting how they went through, and with the help of their actuaries, they split out these various cost components. And so you can see here on the nursing side, it was a 57-43% split between nursing and non-therapy ancillary, and then a 43-40-16 split between PT, OT, and speech language. And we'll talk a little bit about on this next slide here, why they were splitting those various items apart. It really has to do with the way that CMS was interpreting RUGs and how the therapies were factoring into these RUG payments. So it was interesting, when CMS did their look-back analysis, they noticed that 90% of covered SNF services were using at least one of the 23 rehab RUGs that required some therapy component. Then, if they even drilled down further, they could see that of the total population, 60%, so over half, which usually gets their attention, of covered SNF services were using at least one of three of the ultra-high therapy RUGs. And that second point of 60% of covered services, that's really where CMS started to engage with the OIG and others to really determine, if we're paying out ultra-high therapy RUGs, does the documentation and patient care plan really support the need for this high reimbursement? And so what they're intending to do, as we have interpreted the rule, is they're really seeing it not so much as a baseline of reimbursement that's consistent over the resident stay, but more of a tapered effect that as the resident is winding down their recovery period in the SNF, the reimbursement would be tapered consistent with the amount of output from the skilled nursing facility. But as with any profession, it comes down to documentation. It's got to be there. It has to support all of the services that are being provided, because there will be those cases where residents aren't improving over a period of time. And if it is taking that much additional effort and cost input to help that resident get better, we want to make sure that we're getting credit for that. So what CMS was doing with the PDPM is they were also wanting to make sure that there was accurate reflection from the transition from the acute to post-acute space of what the conditions and clinical categories were for those residents who were coming into this space. So what CMS proposed is they would have major clinical categories for the PDPM, and you can see those here on the left, and typical of what we would normally see in that skilled nursing space. And then they also collapsed down PT and OT clinical categories to match up with the orthopedic and other services for those residents. Now, it was interesting that CMS proposed that what they would do is they would categorize a resident in one of these PDPM clinical categories using item I-8000 in the MDS 3.0. They would have used the first line to report the I-10 code that would have represented the classification of the resident coming out of the acute space, and would have represented the maps to one of these categories. But based on all of the comments that were submitted, and you don't see this very often, CMS will typically go on for 3 pages with comments and then have a 1-sentence response saying that they appreciate the commenters taking the time to respond, but nothing's changing. In this case, they actually took the comments to heart and changed that so that the final rule said that instead, CMS would require providers to select as necessary a surgical procedure category within item J2000 of the MDS that would represent the relevant surgical procedure that occurred during the patient's preceding hospital stay, which would augment the patient's PDPM clinical category. So, it could have been stroke related, it could be orthopedic related, it could be cardiovascular, but CMS is really wanting to make sure that providers are putting in those conditions ahead of time so that they understand going into that post-acute care area what the patient was suffering from and is their condition improving while they're in the skilled nursing facility. In terms of mapping, we did include the link here that in the slides that are available. This is actually where CMS goes into deep, detailed discussion on the PDPM there on CMS's website. One thing to note with PDPM is that CMS also did correlation studies between PT, OT, and speech language. And it was interesting, and this goes back to the comment of how they ended up coming up with those percentage splits, that they noticed that when there was an instance where physical and occupational therapy were being provided together, that there was a weak correlation that speech language pathology was also required only 0.04% of the time. But it's interesting that when it was just PT and OT together, that there was a close correlation between those two services needed in conjunction for resident care. So a fairly high correlation of 0.62. Now, for those folks on the line, what you see in your daily operations, that's probably a no-brainer, but sometimes it takes CMS to go back and really dig into the detail to really understand from both claims data and other reporting metrics what folks are actually encountering in the marketplace to take care of Medicare beneficiaries. And with that, we will move on to our next polling question.
All right, our third polling question. Has your facility started the planning process for the impact and operational changes required to align with the PDPM? And your options are yes, no, or I'm not sure. And for those of you that would like a copy of today's slide deck, you can download them now from the folder that says Slide Deck and Handouts to the right of the slide view. We will also be sending the slides via email after the webcast. And that link that Paul just mentioned is available in this Slide Deck and Handouts widget as well. And let's see what everyone had to say. Paul, back to you.
Very good. Thank you, Emily. Yes, at this point, we would expect quite a numbers of not sure. We're very early in the process. We're still, whether it's consultants or operational folks or even the facilities, still wrapping our heads around what this really looks like, making sure that all of the other operational items, whether it's documentation, MDS, those things are in place. And then even more importantly than that, folks, as they're heading into year-end budgeting, really trying to understand what the differential in reimbursement might look like. So more to come on this. Certainly stay tuned. From our team at Moss Adams, we will be continuing to roll out white papers and one-sheets and best practices for our clients and others in the marketplace to really understand what this looks like. It's going to be a significant change. And as with any change that Medicare makes, it's very interesting from Medicare's perspective because their charge in the Social Security Act when they created prospective payment systems was that they could only make changes to payments and other methodologies going forward. That the prospective nature of that basically indicated that they couldn't go back and recoup funds. They could only make changes going forward based on the data that was being submitted. So that's why we saw the increase in OIG, recovery audit contractors, ZPICs, all of these bodies that were created by the federal government who could look backward and recoup funds that way. So it'll be interesting to see after Medicare makes a change like this PDPM, similar to the changes that they did with DRGs and APCs on the acute care side. It's always interesting to see a year or two down the road how they begin to calibrate their payment methodologies based on the new data that starts rolling in. So with that, I wanted to just highlight here, this was from an article that I had read that basically just disclosed what the top 5 diagnoses were, and I thought in the framework of this discussion, it was interesting to see by I-10 code what the various diagnoses were. I think UTI is interesting that it's on this list because we'll talk about that a little bit later in a slide from the OIG, that UTI and certain facility-acquired conditions are definitely on their radar. One other item to note from the regulatory environment is how observation status is playing into confusion and concern on the behalf of not only the skilled nursing facilities, but also on the residents and beneficiaries themselves. As we know, at least currently, a qualified 3-day inpatient hospital stay is what is still required for Medicare SNF coverage. It's unfortunate that in a lot of cases, a Medicare beneficiary will be in an acute space. The family will come and visit them. They're in a bed. They're being served meals. The nurses are checking on them. There's Holter monitors connected. So if you didn't know any better, you would think that they were an inpatient in a hospital. They're there for 3 or 4 days, and then they're discharged to a skilled nursing facility. Come to find out that they were actually in observation status the whole time, and then the Medicare beneficiary gets a bill for $25,000. This creates just a lot more work for the skilled nursing facilities to really coordinate care and communicate out to those residents what their obligation might look like, depending on what status they were in prior to discharge. Back in 2013, there was a bill that was put forward to Congress that would consider a 3-day stay in observation as counting toward SNF coverage. Unfortunately, at this point, it's still stuck in committee, but we'll see if that changes over the next couple of years. CMS also has their Meaningful Measures Initiative. This is where they're really trying to focus on quality for the beneficiaries. A couple of items to note under the objectives. Really it's about public safety, it's about quality, it's about making sure that dollars aren't needed to be spent on kind of backtracking on certain items. But it really is interesting to see that this last bullet point about the alignment across programs and or with other payers and providers. It'll be interesting to see that not only do the Meaningful Measures Initiative affect the quality of care in a skilled nursing facility, but it's also going to come down to what data is available and can be shared between the acute and post-acute providers in the marketplace, and how is that data in those electronic health record systems facilitating and improving the handoff of patients, whether it's medication reconciliation, really understanding a patient's condition, what status they were in upon discharge. There's a lot of information that can be shared across the spectrum, and I think CMS is really going to start looking at how that is working. They spent all this money on EHR incentives to roll out these programs, and I think it's really going to come down to pressure on the EHR vendors themselves, whether it be Epic or Cerner or others, to really figure out how interoperability is going to play out over the next couple of years. So this is just something to note from the rule in terms of the meaningful measures. Obviously, the quality priorities along the left, which are from the previous slide, and then all of the various areas that folks are focused on. And I think we can see in here in terms of the various areas that we have, medication reconciliation, prevention, management of chronic conditions, so on and so forth. So a lot of various areas that CMS is paying attention to within both claims as well as quality data. So with that, we'll move to the second half of our presentation here. We've talked about the regulatory updates, the reimbursement, understanding really what that change looks like at 100,000-foot level. Now, in conjunction with all of that, we still have to keep in mind that the OIG is out there looking for deficiencies with providers and others in the marketplace. So here's several items that we wanted to highlight in terms of ongoing action items from the OIG. This is from the 2017 OIG work plan. One thing that they noted in 2017 was that nursing home complaints are categorized typically into two major categories: immediate jeopardy and actual harm. And with those two categories, there are time frames that are placed on those in terms of addressing and rectifying and reporting back those conditions. What's interesting is, and this comes up quite frequently in the OIG work plan, is that a deficiency is reported or a survey is completed. The state comes in, they're doing their work, but there isn't a lot of follow-up from the state once these action items are brought to the table. So one thing we want to really keep in mind is if for whatever reason one of these types of items, either immediate jeopardy or actual harm, is brought forward at your facility or elsewhere, it's really important to make sure that not only is it reported within a timely manner, but it's also responded to and documented within a timely manner. That is very important, because if your state surveyors or others come in, you want to make sure that all on the management team are aware of what happened, it was addressed, it was documented, because as we always say in the accounting world, if it wasn't documented, it didn't happen. And so just making sure that you're keeping an eye on all of these items that the OIG is as well, but also making sure that you have the backup to support it. Also, in conjunction with those two complaint categories, we have unreported incidences of abuse and neglect, really making sure that protocol is followed for those instances of abuse and neglect. The MDS on that third bullet point, it'll be interesting to see as we move away from RUG-4. Obviously, the OIG's mandate is to retrospectively go back and review. So just because we're moving from RUG-4 to PDPM doesn't let providers off the hook for what happened previously. So really making sure that that documentation is in place, supporting those therapy levels that were provided. And it's interesting on this last bullet point as well that CMS is putting in a screening tool, really trying to look for those instances of adverse events. They are really on the lookout for residents who are in a situation that are detrimental as opposed to improving their condition. This first bullet point talking about background checks, we cannot stress this enough. I do several co-presentations a year with healthcare lawyers who work with both acute and post-acute providers all over the West and even East Coast. This is one area, if you take nothing else away from the presentation, make sure that your HR and other teams, when they are onboarding new employees with direct access to patients, that you are not only going through the standard background check process, but you are going through and looking for current names, assumed names, maiden names, any name that could have been used historically on a job application or other reporting items. Make sure that you're working with HR and your counsel on this, because there are many instances across the nation where an RN will come in, or even a physician, and under their previous maiden name, Johnson, they were excluded from the Medicare program, they got remarried or they changed their name legally, and now they're Smith, and Smith was the name that was used to verify their employability. Come to find out, they've been working in the skilled nursing facility for 6 months, and all of a sudden there's an investigation and there has to be a recoupment because you were employing someone excluded from the program. Very important to go through and make sure that this is an active part of not only onboarding but your compliance plan as well. The couple of other items here, the last bullet point really is, consistent with what we've seen with other OIG reports and quality metrics. As we point out here, this is where the UTI comes into play. There's a lot of readmission to the acute space for UTI, as well as pressure ulcers and some of those other conditions. So really making sure that if a resident is being discharged from your skilled nursing facility back to the acute space, that the documentation supports that it's for a condition that was not acquired due to negligence or other factors within your control, that it was, maybe they were in for cardiovascular recovery and they ended up having a stroke, but that was beyond the control of the facility. So just making sure that all of those items are really documented well will help to mitigate some of those issues. In terms of the 2018 work plan going forward, historically, for the folks on the line who reviewed the OIG work plan, it used to be issued in the fall. It was a fixed document on what the OIG was going to be working on heading into the new year. Now the OIG work plan is a dynamic document. The OIG will add and subtract work plan items almost in real time as they conclude certain studies and other investigations. So it's really important to keep a link to the OIG's website active and part of your overall planning process. 2 items that they are focusing on, at least heading into 2018 and 19, opioid misuse. That's a huge action item for them right now. They're seeing that even folks in the skilled nursing, IRF, IPF, the misuse or the overuse of opioids, even in clinical settings, is reaching a level of concern consistent with what folks are seeing out in their communities as well. And then orthotics devices. We all know that DME is always a hot button issue for the OIG. So just making sure that if you have DME, either as a subsidiary of your operations or if you work with a DME provider, just making sure that all of that, the documentation, eligibility, all of those things are all working in lockstep. So with that, in the spirit of the OIG, we want to talk a little bit about compliance plans. And this, as I mentioned at the outset, is a little bit more of a reminder than something new. But because it's so important to the operations of the long-term care community, we really wanted to iterate it while we were on the line today. Making sure that you have an effective compliance plan. Obviously, compliance plans can be a broad form of internal controls. You have to make sure that the compliance plan is a living, breathing document within your operations. Even if you have a compliance plan, but you have a lack of key controls in place, then the compliance plan may not exist in the first place, because those two have to work together. Now, really, Section 6102 of the ACA really built this out for the skilled nursing community. Obviously, the OIG had standard compliance plan requirements in place. The ACA built on those, and we wanted to just refresh on the line today about what some of these specific items are. We really want to make sure, first and foremost, that there are standards and procedures in place that have the ability to reduce even just the prospect of criminal, civil, or administrative violations. We just have to make sure that those key controls are in place that help put in some of those barriers or would be able to identify if something was happening. You have to make sure that high-level personnel in the organization have assigned responsibility, that they are actively managing the compliance plan, but it's not just enough for the high-level personnel to manage the compliance plan. It has to be implemented organization-wide, so that if a surveyor came in and bumped into one of the dietary staff and asked, do you know where the compliance plan is, or have you been actively educated on what the compliance plan is, they would at least be able to say, yes, we had an in-service last month, and we were talking about updates to the compliance plan. You want to make sure that top to bottom that it's a living, breathing document overall. Making sure that you're able to not to delegate authority to individuals who might have the ability through negligence or otherwise to exercise criminal wrongdoing. Making sure that you're communicating the compliance plan effectively to all in the organization. It's not just enough to take care of it during onboarding. You may not go through the compliance plan page by page during your in-service, but making sure that employees and patient care personnel who are aware of what's required understand that that is their charge day in and day out. We'll talk in a minute about auditing and monitoring, but making sure that auditing and monitoring of your internal control systems are identified in the compliance plan and then implemented accordingly going forward. And then consistent enforcement is extremely important. Once something has been detected or identified, making sure that the compliance plan and other operating protocols allow the organization to respond appropriately, that it's documented, that action has been taken. Very important. And then number 8 was one of the ones that was added, and this is really important, is that it constantly needs to be reassessed. Making sure that you're going back and you're looking at the compliance plan, the compliance program, year over year as part of your both short and long-term strategic planning. And it's that much more important as the reimbursement models continue to evolve year over year. And with that, Emily, we'll move to our last polling question.
All right, thank you. Our final question, in the past year, has your facility reviewed and or reassessed your compliance plan? Your options are yes, no, or I'm not sure. And once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the certification widget to the right of the slide view. I'll give everyone a few more seconds to make a selection. And let's take a look at the results. Paul, back to you.
Very good. Thank you, Emily. Well, that's good to see. Almost half have reviewed or reassessed. I would encourage those individuals who are either no or not sure to work with your management teams, with your internal audit, internal counsel or external counsel, or consultants who specialize in compliance plans for skilled nursing facilities. This is very important, just making sure going forward that you've covered all of your conditions of participation and compliance plan requirements, because obviously with everything else to focus on, we definitely don't want something like this to be a hang-up for our clients and prospects. So in the spirit of talking about the implementation of the compliance plan, let's talk a little bit about risk assessment. Really, from a risk assessment perspective, these really should be done under the direction of internal counsel. One thing that the healthcare lawyers that I present and work with frequently talk about is making sure that the executives in an organization really understand what it means to do something under attorney-client privilege. In the spirit of areas where a billing concern or a payback or self-disclosure comes into play, making sure that attorney-client privilege is intact so that the investigation, the quantification, and the reporting can all be done under the direction of counsel, which will allow you to mitigate certain areas of discovery and keep some of those protections in place. I am not an attorney myself, so I couldn't tell you all the specifics on that other than it's better to reach out to counsel on the front end than midstream. making sure that once that protection is in place, that you are reviewing your existing documents, conducting interviews, testing transactions based on interviews, and then developing a list of risk areas. And your list of risk areas won't necessarily be fixed. They can be dynamic over a period of time. And we typically encourage folks, once you've developed your list of risk areas, to review them kind of from a Pareto format, where you're really kind of tackling the 80% the 20% of items that are creating 80% of your issues, and kind of seeing, we want to make sure we don't have to review everything, but we need to make sure we're handling those things that are creating the biggest problem. Now, it's interesting, in conjunction with your risk assessment, using reports like Pepper to go through and see what CMS and others are looking at can help frame out some of those risk areas. So within Pepper, looking at those therapy rugs with high ADLs, non-therapy rugs with high ADLs, COT, ultra-high therapy rugs. And then the last point is really important, those episodes of care that are lasting more than 90 days. You're getting toward the end of the beneficiary's coverage period, and really targeting some of those items where, it doesn't appear as though an individual is getting better, and really understanding, what that is and why can be a key part of your risk assessment. Within the SNF Part A data itself, obviously these are fairly standard for folks on the line, but just keeping in mind, again, the component of that ultra-high therapy, how long the individuals have been in there, and then really that discharge destination. Where are they going when they're leaving the SNF? Are they going back into the acute space? Are they going home? Are they going into home health or hospice? Really understanding, where your skilled nursing facility is on the continuum of care can help level set some of your risk assessment as well. Now, when we're doing auditing and monitoring, we want to look at it from a risk-based approach, and then we also want to look at our policies and procedures. We want to establish monitoring systems, but we really need to understand that auditing and monitoring are not the same thing. When we're talking about auditing and monitoring, we need to really focus, as I mentioned before, on looking at whether or not we need to consult with counsel, depending on the nature of the issue, make sure that we're documenting and reporting, and that we're making sure that we can identify if there's a pattern of this as well. And the important part with this is that auditing and monitoring go in two different directions. Monitoring is really part of your daily activity. Your internal auditors or others might look at something on a daily basis. You might look at average length of stay, or you might be looking at certain patient conditions or staffing reports as part of your daily monitoring. Once you have done all of your monitoring and you really understand what the data is telling you, at some point in time, based on a particular frequency, quarterly, biannually, annually, then you will go back and you will do your auditing based on all of the monitoring activity that you have completed up to that point. So really understanding those two is important, because one is now in real time and one is retrospectively going back and really understanding whether all those monitoring efforts did what they were intended to do. So within those auditing processes, when we go through and test transactions, we can look at AP, we can look at therapy and ADL coding, we can look at our MDS, you could even look at overpayment and refunds. And then, on the monitoring side, as I mentioned before, there's all manner of areas that can be monitored. These are some that we know have come up as a function of OIG and other reviews on a daily basis when you're going through, looking at therapy time, looking at concurrent therapies and other areas that are being performed in that space, going back and basic quote, end quote, auditing the completeness of the patient care plan, but on admission. Once it's actually completed, are we going back in real time and making sure that everything is in the patient care plan that needs to be? And then looking at those patient safety initiatives. If there was a fall, if there was an area where either a staff member or a resident was injured, are we monitoring and actively looking at that as it either happened or within a fairly short period of time? And then it's also important to audit the auditor, really looking at, if we have individuals who are going back and doing those retrospective reviews, did they cover all the areas that we would have expected them to? And to that second bullet point there, making sure that for whatever reason, there's no personal bias. Obviously in some smaller facilities or organizations, you want to make sure that the auditor could be friendly or friends with other folks on staff. There's nothing wrong with that, but when it's time to do the auditor review, we have to make sure that individuals are being objective. In conjunction with all of this, developing a set of warning signals, looking at some of those areas, and especially speaking to that third bullet point, are we seeing these interesting illogical patterns? Are things popping up either in the MDS or when we're assessing some of those ADLs or therapy patterns? Are things happening where it looks like we're having to do all of this extra work, but the types of residents who have been coming in don't look that different? Making sure that you can separate those two and really understand your patient population as well as what the data is telling you, and working with those two side by side could help mitigate issues that aren't expected or are only found out 1 or 2 years down the road. And then making sure with that risk profile, if CMS and Noridian or other Medicare contractors or RACs or ZPICs, if they're using your claims data to identify issues, you should be using your claims data to identify issues to make sure that if they're coming to the table with something, that you have already either been aware of it or you are actively monitoring that day in and day out. With all of the data that's available out in the marketplace right now, there really isn't a whole lot of reason why a regulator should have access to something that you wouldn't have access to as well. You may have to go out and purchase it, or you may have to identify where that data source is going to come from. But with all of the available big data out there right now, we really have to make sure we have all the tools that we need coming into those negotiations. And then some of the higher risk areas that we're running into, certainly there's risk areas at the board level with conflicts of interest, inurement, making sure that those individuals who need to recuse themselves from certain transactions are doing so. Are our transactions commercially reasonable? Are we making sure that that everything is arm's length? Physician contracts, medical necessity, substandard of care. And to that second to last bullet point, making sure that as part of that onboarding process, we did everything to the best of our ability to have avoided employing anyone who has been excluded from the Medicare or Medicaid program. This is an area that we wanted to call out specifically for individuals who have executives and board members who had not heard of the Yates memo previously. Sally Yates was a U.S. attorney who put together a memo, and really what the Yates memo is intended to call out: when fraud or other areas are perpetrated, it's not necessarily the brick and mortar of the building that created the fraud. It was an individual or individuals within the organization who initiated it, but historically, when penalties or fines had been handed down, they had been levied against the organization and not necessarily against individuals. And so what the Yates memo attempted to do was to really call out the fact that not only should the organization, but the executive team or board members or board chair should be joint and severally liable for some of these items. And so as we can see, the government is using all manner of enforcement tools. They're using key tam, whistleblowers, they're levying substantial fines, they're kicking folks out of the program. I know for most of the individuals that I work with, if they were excluded from the Medicare program, it's game over. And so making sure that all of those areas are being met. In some cases, there have been criminal sanctions, and I guess the least scary is a corporate integrity agreement, but CIAs require a tremendous amount of administrative burden to work out of them. So we wouldn't want anybody to go through any of these, let alone one. One thing we are seeing, though, is that the government is very serious about this. An instance here at the last bullet point, there were charges alleged against a nursing home provider. I believe this nursing facility was on the East Coast. CMS and the OIG determined that there was a lot of unnecessary therapy happening for facility residents. The board chair was required to pay a fine of $1 million. One of the vice presidents, $500,000. Home health, similarly, there's a lot of settlement out there that's happening that's not just the CEO or CFO or even the organization. The board chair is also being penalized as well. So making sure that open communication channel is intact, because the government is very serious about going over and making sure that folks are being reprimanded accordingly. And as our time winds down here, one thing to mention is the reason why the government is doing this is they have a profit motive. For every dollar that the government spends on enforcement, as of 2014, their ROI was $8. So when they're going out, they're finding that there are a lot of providers, regardless of where they fall on the continuum of care, documentation isn't there. It could, in some cases with the DME providers, the Medicare beneficiary never even existed in the first place. So the government knows that those issues are out there, and they're going to recoup that money in a big way. So you have to make sure that you're staying out in front of these items, because the government certainly is on the lookout for them. So in terms of our takeaways today, making sure that while RUG is still in existence, we're making sure that we're getting all of that documentation in place. PDPM is here. We're looking at 10/1 of 19 as an implementation date. Keep an eye out for more content from us on that. The OIG, always on the lookout. Make sure that everything in the residence care plan, the medical record, all of that, everything is working as you would have expected it to, and really making sure for those folks on the compliance plan slide who are either no or not sure, I would definitely put that as an action item for the near future to make sure as you head either into mid-year or year-end that you're really making sure that everybody is on the same page with compliance. So let's see here. With that, I appreciate everyone attending this morning. A lot of information to cover in 60 minutes. There's a lot going on in the marketplace, a lot coming down from a regulatory standpoint. So we appreciate you taking the time to be with us here. And with that, I will turn it over to Emily.
All right. Thank you, Paul, for a great presentation today. We certainly had a lot of material to cover, and unfortunately we don't have time for questions. If you do have a question for Paul, you can reach out to him directly, or you may still submit questions in our Q&A window. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts icon to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy will be emailed within 2 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.